Welcome to Talking Ketamine. This is episode 18. Now, you've likely heard about ketamine therapy making some real waves, particularly for conditions like depression.
Definitely.
But what about those other mental health challenges? The ones that are often really complex, maybe don't respond so well to the treatments we already have.
That's the big question we're digging into today. We're looking specifically at the potential for ketamine-assisted psychotherapy, people call it KAP, for something as notoriously tough as anorexia nervosa, or AN.
Okay, AN. And to really get into that, we're going to zoom in on a pretty fascinating single case study.
Right. One person's story can tell us a lot sometimes.
Yeah, and this exploration, it's based on a report that was published just recently in 2025 in the Journal of Eating Disorders.
Okay.
The paper's called Reconnecting Through Dissociation, a 5-month follow-up case study on ketamine-assisted psychotherapy for anorexia nervosa. It's by Camilo Lindvall-Dahlgren and her colleagues.
Got it. So Dahlgren et al., a really focused look.
Exactly. And our aim here is to try and understand what this detailed look at one person's journey might tell us about using KAP for anorexia nervosa and, what it could signal for future treatment directions in this really difficult area.
Yeah, definitely a challenging field.
So before we jump into the ketamine part, let's quickly frame the problem itself. What makes anorexia nervosa such a tough condition to treat?
Well, at its core, AAN involves incredibly rigid thinking patterns and behaviors. It's not just about food and body shape, though that's central.
Right.
This rigidity, it often spills over. You see it in exercise habits, sometimes work, relationships. It's this kind of pervasive inflexibility that takes hold.
And it rarely travels alone, does it?
That's a huge factor, yeah. High rates of comorbidity. So things like depression, anxiety, PTSD, even self-harm, these tend to pile on and they definitely complicate the picture. They can make the illness last longer, make it much harder to manage day to day.
And the severity, we can't understate that.
Tragically, no. AN has the highest mortality rate of any psychiatric disorder, period.
Wow.
And that's a stark reality driven by both severe medical complications from starvation and malnourishment, but also a significantly high risk of suicide. It's incredibly serious.
So given that picture, how well do our current standard treatments actually work? Things like, say, cognitive behavioral therapy or medications.
They certainly help some individuals, absolutely, but their effectiveness really varies. This report notes that many patients still face persistent symptoms. They struggle with relapse even after treatment.
So it's not a guaranteed fix.
Not at all. Fewer than half achieve what we call full remission, and a significant number end up battling a sort of persistent or chronic form of the illness for years. So there's a clear unmet need for treatments that can address not just the core eating disorder symptoms, but also these common co-occurring conditions alongside them.
Right, tackling the whole picture. And this is where ketamine starts to enter the conversation, isn't it? We often hear about its rapid impact on depression.
Exactly. At these lower sub-anesthetic doses, the ones used in therapeutic settings, ketamine has shown these remarkably swift antidepressant effects.
Yeah.
And that's what's made it such a promising area of research for treatment-resistant mood disorders, for anxiety, PTSD, even suicidal thinking. And as this paper highlights, researchers are now starting to explore its potential role in eating disorders, too.
So what's the thinking behind how it might work, especially for something like AN? With that rigidity we talked about?
Well, the main hypothesis, the leading idea, centers on the glutamate system in the brain. Ketamine is thought to modulate this system, and that in turn seems to stimulate neuroplasticity.
Neuroplasticity. Okay, so the brain's ability to change.
Exactly. You can think of it as the brain's ability to form new connections, to reorganize itself. It's almost like ketamine might help the brain build new pathways, sort of workarounds for those old, deeply ingrained, stuck patterns of thinking and behavior common in AM.
But I've heard those rapid changes from just ketamine alone can sometimes be, short-lived.
Precisely, and that's the whole rationale for combining it with psychotherapy, creating ketamine-assisted psychotherapy, or KAP.
Okay.
The idea is that ketamine might create this temporary neuroplastic window, like a period where the brain is more flexible, more receptive, and during that window, the patient might be more open, more able to engage deeply with the therapy work.
So the therapy helps kind of anchor those potential changes.
That's the goal, to integrate insights, practice new ways of thinking, new behaviors, while the brain is potentially more open to it, making the benefits last longer.
Okay, that makes sense. Let's turn to the individual at the heart of this specific case report then. Who was she? What were her challenges going into this?
Right, so this was a woman in her late 20s. She initially sought treatment for depression at a private clinic in Oslo, Norway. But she also had this long-standing diagnosis of anorexia nervosa, along with that comorbid depression.
And what had her experience been like with treatment before trying KKP?
She reported being really plagued by persistent, intrusive thoughts. Constant thoughts about food, about her body image. She'd tried other things before. SSRI antidepressants had helped her depression somewhat, but didn't really touch her energy levels or draw back positive emotions.
Okay.
And previous therapy, she felt, hadn't fully explored some of the deeper personal history, like maybe childhood issues or self-esteem. And she'd also struggled with adhering to past treatments, especially anything that involved gaining weight.
Understandable difficulties. So what was she hoping this different approach, the KAP, might offer her?
Her goals were pretty clear. She wanted to boost her energy, improve her emotional flexibility, feel less rigid, emotionally enhance her overall quality of life, and crucially, quiet down those overwhelming, intrusive thoughts that were taking up so much space.
And what was her physical state when she started?
At the intake assessment for this ketamine treatment, her body mass index, her BMI, was 17.0, which is classified as underweight, and she was actually on full sick leave from work because her condition was so impairing.
Okay, so clearly struggling significantly. How did the clinic structure the treatment protocol for her?
It was a structured, multi-phase approach. First, she went through what they call the KAP phase. This involved 4 intramuscular ketamine treatments, so IM injections.
Not Muvy.
No, IM in this case. And each of those ketamine sessions was explicitly paired with an adjunct psychotherapy session right after. These were scheduled about 1 week apart.
Okay, 4 KAP sessions, and then you mentioned boosters later.
Yes, about 2.5 months after that initial series finished, she received 3 additional ketamine booster doses. Now, interestingly, these were given over a much shorter time frame, just 11 days apart. And a key difference, these booster doses were administered without the formal, dedicated psychotherapy sessions alongside them. That was apparently at her request.
Oh, okay, so boosters, but just the ketamine. And you said IM administration. How does that compare to IV infusions, which we sometimes hear more about?
Right. IM injection, usually into a large muscle like the upper arm or thigh, is another common way to give ketamine therapeutically. FARV infusions are maybe more typical in some research settings, but IM offers very similar bioavailability, basically, how much drug gets into this system effectively.
Okay.
But it can be more practical in certain clinic settings, less specialized equipment needed, maybe less intensive monitoring than a continuous IV drip. The doses they used here varied a bit, but they started around 0.5 milligrams per kilogram and went up, kind of in that standard therapeutic range.
And what was the actual session like? The environment?
They aimed for supportive and comfortable. She'd typically be in a reclining chair, often using an eye mask to help focus inward, and listening to soothing music through headphones.
Mm-hmm.
And crucially, healthcare staff, a doctor, nurse, or psychologist, were always present, monitoring vital signs, providing reassurance if needed. Then, after the main acute effects of the ketamine wore off, usually around 60 minutes post-injection, they'd lower the music, take off the eye mask, and transition into a period of reflection and discussion about the experience and linking it to her goals.
And the therapy part, the P in KAP, what kind of psychotherapy were they using?
The specific framework integrated with the ketamine was acceptance and commitment therapy, or ACT.
ACT, okay, I've heard of that. It feels like that approach could be particularly relevant for AAN. What's its main focus?
It really is relevant. ACT is all about building what's called psychological flexibility. It encourages people to identify what truly matters to them, their core values, and then take committed action towards building a life aligned with those values.
Even with difficult stuff present.
Exactly. Even when difficult thoughts, feelings, sensations show up, a central idea is sometimes summarized as accept what is changes. It's less about fighting or eliminating difficult thoughts and more about changing your relationship to them so they have less power over your actions.
That sounds potentially very helpful for someone stuck in rigid patterns.
Yeah.
How did they actually apply ACT within these ketamine sessions?
They use techniques like body scanning, mindfulness exercises, focusing on breath. These helped her explore her internal sensations, physical feelings, emotions, without that immediate pressure to label them, judge them, or push them away. That can be really hard for someone with AN who might struggle with identifying emotions, what we call alexithymia, or have a very fraught relationship with body sensations.
Right.
So they work directly on the ED-specific topics, food, weight, body image, but they also use that potentially more open state during or after ketamine to explore those deeper issues she felt hadn't been addressed before, like her childhood experiences and self-esteem, really leveraging that potential window.
Okay, so we have the setup. The initial KAP series
Yep.
with ACT, then a break, then the boosters without formal therapy alongside, all tracked over 9 months with assessments. What did those assessments actually show? What were the outcomes?
Right. They measured things at 5 key time points. Before starting anything, right after that initial 4-session KAT phase, then again before the booster shot started, immediately after the boosters finished, and finally at a 5-month follow-up after the last booster.
And was there a clear pattern in the data across those points?
Yes, there was a consistent and honestly quite striking pattern. They saw marked symptom reduction right after the initial KAP phase, the ketamine plus therapy part.
Okay.
Then, interestingly, during that interval between the KAP series and the boosters, when she wasn't having the formal therapy sessions, her symptoms showed a temporary increase again. Not back to baseline, but a noticeable worsening.
Ah.
Then, once the booster phase started, symptoms declined again or stabilized, and these improvements were largely sustained at that 5-month follow-up mark across most of the measures they used.
That pattern itself seems really telling. Let's look at some specifics. What about the eating disorder symptoms themselves, measured by the EDQ?
Yeah, the Eating Disorder Examination Questionnaire. Her global score, which is a general measure of eating disorder pathology, it dropped significantly. It started quite high, 4.84 at baseline. After that initial KAP phase, it plunged down to 1.28.
Wow, that's a big drop.
Huge. It did tick up a bit before the boosters, aligning with that pattern, but then settled at 0.91 at the 5-month follow-up. And importantly, scores below about 2.8 are generally considered to be in the non-clinical range.
So a massive improvement maintained long-term on that measure.
Yes, and the subscales, things like restraint, eating concern, shape and weight concern, they all showed similar major reductions.
Okay. What about the comorbid issues, depression and anxiety?
Similar picture, really dramatic improvements there too. Her PHQ-9 score for depression went from 15 at baseline, which is moderately severe depression, down to just 5 after the initial KP phase, putting her in the mild range.
Big shift.
Yeah. And her GAD-7 score for anxiety went from 9, which is mild anxiety, all the way down to 0 after the KAP sessions, basically reporting no anxiety symptoms. Like the EDEQ, these scores fluctuated a little, but stayed in that mild or no symptom range through the follow-up.
And that psychological flexibility you mentioned, measured by the AAQ2, how did that track?
That measure showed basically the inverse pattern to the symptoms, which makes sense. Psychological flexibility increased significantly right after the initial KAP phase. Then it decreased a bit during that therapy-free interval between KAP and boosters, and then it improved again after the boosters.
So her ability to be psychologically flexible seemed to track pretty closely with her symptom level?
Exactly. It really supports the idea that flexibility is key, and maybe the KAP was enhancing that.
And quality of life, did that...
Very significantly. They used the EQ-5D-5L measure. At baseline, she reported moderate to severe problems across various dimensions, things like mobility, self-care, usual activities, pain, discomfort, anxiety, depression. Her profile was something like 32423. After the KAP sessions, she reported no problems at all on any dimension, a profile of 11111. And that generally high quality of life perception was largely maintained throughout the follow-up period.
That's quite a turnaround. Any suicidal thoughts reported?
According to her self-report on the MA-DIOR 10 item for suicidal ideation, her score remained at 0 throughout the entire assessment period, from baseline onwards.
That's obviously very positive. Okay, shifting gears a bit. How well did she actually tolerate the ketamine itself? Were there significant side effects?
Generally, the report indicates it was quite well tolerated. There was one instance mentioned early on when they increased the dose where she experienced some nausea and vomiting, but it resolved quickly and didn't happen again.
Okay.
She did report some of those common temporary post-ketamine effects, things like feeling dizzy, maybe fatigued, or having a headache shortly after sessions, but these were expected and transient. No other significant adverse events were noted.
Anything else interesting about side effects?
Yes, actually. They looked at scores on the ketamine side effects screening tool, the KSET, over time. And what was really interesting is that she actually had notable scores on some items at baseline before she ever received ketamine.
Like what?
Things like moderate dissociation, some anxiety, drowsiness, these were present before treatment. But the striking finding was that her total K-set score at the 5-month follow-up was actually lower than it was at baseline.
Lower. So the treatment didn't worsen those, and maybe they even improved.
It suggests that, yeah, it suggests the treatment didn't exacerbate these issues long term, and that the lower score might even reflect her overall improvement in baseline difficulties, rather than indicating persistent side effects from the drug itself. No new side effects were reported at follow-up either.
Fascinating. Okay, now the really critical question for anorexia nervosa. What happened with her BMI and weight?
Right. So she started underweight, BMI 17.6. The report states that during the structured treatment phases, both the initial KAP and the booster phase, she successfully maintained her BMI within the normal healthy range.
Okay, that sounds positive during treatment.
It does, however, and this is a really important however, the report notes that she did experience significant weight loss after the entire treatment series had concluded during the follow-up period.
Oh, that seems, concerning and maybe contradictory to the other improvements.
It definitely adds a layer of complexity and highlights a critical point about treating AN. It turns out the patient disclosed, sort of after the main data for the report was collected, that she had actually started following a ketogenic diet around the time she began the ketamine treatment.
Ah, ketogenic diet while being treated for AN.
Yes, and she apparently continued it afterwards. So this significant post-treatment weight drop, potentially influenced or driven by that dietary choice, it just really underscores the absolute necessity for incredibly comprehensive, individualized follow-up plans and ongoing support for relapse prevention in a condition like AN. Recovery is rarely linear.
Absolutely, a crucial piece of context. Okay, beyond the numbers and the weight fluctuations, what did the patient herself say about her experience? What was it like subjectively during and after the sessions?
Her descriptions of the ketamine sessions themselves evolved over time. Initially, she said they were minimal, like being in a dark room, but gradually they shifted. She started describing sensations of floating, tilting, seeing calming natural scenes like forests or oceans.
Okay.
And critically, she increasingly reported feeling this sense of calm, a feeling of connection, even feeling love during the sessions. Sometimes these feelings felt deeply resonant with the music she was listening to.
And how did those kinds of experiences seem to influence the therapy work?
It seems like those states created a different kind of mental space for her, a space where she could maybe approach her eating disorder struggles, including that intense internal conflict between wanting recovery, but also holding on to rigid beliefs about weight, maybe from a slightly different, less defended perspective.
What about changes she noticed in her everyday life outside the clinic?
She reported some really significant shifts, feeling generally calmer, more relaxed. She mentioned a greater connection to her own emotions, specifically highlighting feelings of love and hope emerging.
That's not positive.
Yeah, and she started experiencing moments of body acceptance, describing feeling her body was okay or okay to be in, which is huge for Anne. She felt she had increased energy and vitality, which allowed her to re-engage in meaningful activities she'd stopped, like jogging and socializing more.
Any relational changes?
Yes, a big one. She reported finally opening up to her mother about her struggles for the first time, which significantly improved their relationship and brought her a lot of relief. She also noticed this heightened sensory awareness, particularly around food smelling and tasting things more fully, finding it pleasurable, which is often lost in AM.
So overall, how did she feel after the whole series?
She described the sense of lightness, she said, that was independent of actual weight changes. She found a sense of peace in letting go of constantly weighing herself. Importantly, she felt the sessions helped her visualize a future free from the grip of the eating disorder, which really fostered hope and motivation to continue her recovery journey. The report specifically highlights those subjective feelings of connection and love during sessions as potential key mediators for the positive changes she experienced.
Okay, so pulling all these threads together, the assessment data showing improvement, her own positive subjective experience, the treatment structure itself, what does this one case study, recognizing its limitations, suggest about the potential for using KAP in anorexia nervosa?
I think it strongly suggests that the combination of ketamine and therapy holds real promise. That pattern we discussed, clear improvement after KAP, the temporary slip when therapy was paused during the boosters, then renewed improvement, it really points towards a synergy between the drug and the psychological work.
Yeah, that difference between the initial KP phase and the boosters-only phase seems like a really key finding here.
I agree. It really seems to highlight the likely importance of that adjunctive therapy component. It's like, while the ketamine might crack open the window, as we said,
Right.
it seems the guided psychological work within that window, especially work that directly addresses those complex, deep-seated AN issues and helps build new skills, is probably crucial for consolidating those gains and maybe preventing relapse down the line.
So the ketamine might be the catalyst, creating the opportunity, but the therapy is maybe the engine that helps drive and sustain the change using that open space.
That appears to be the most plausible interpretation based on this case, yes. Ketamine potentially enhances that cognitive flexibility,
Hmm.
making the brain more receptive. And this allows a therapy like ACT, with its focus on acceptance, values, and working differently with difficult internal experiences, to maybe land more effectively. It helps the patient build genuinely new coping strategies and perspectives around their eating disorder.
Now, you mentioned something earlier that adds another layer of complexity, another variable to consider, particularly for the long-term data in this specific case.
Yes, and it's really important context for interpreting that 5-month follow-up. The patient disclosed, after the report was compiled, that she had actually participated in a psilocybin retreat sometime after her final ketamine booster session, but before that final 5-month assessment.
Ah, psilocybin. So another psychoactive substance with therapeutic potential.
Exactly. Which means the positive outcome they observed at that 5-month mark could potentially have been influenced, at least in part, by that psilocybin experience, not solely the ketamine treatment series she received earlier. It just underscores the complexities researchers face in real-world clinical situations where patients might pursue other interventions concurrently or sequentially.
Absolutely. A reminder that real life is messy. So, while this case is undeniably exciting, generates interesting hypotheses, it's absolutely critical to view it with the necessary scientific perspective. What are the big limitations here, and what do researchers still need to figure out?
That's the crucial next step, acknowledging limitations. First and foremost, this is just one single case study.
Right, N1.
Exactly. While it provides incredibly rich, detailed, hypothesis-generating data, we absolutely cannot generalize these findings to everyone or even many people. With anorexia nervosa, NN is such a complex, heterogeneous illness. One person's response simply doesn't predict another's.
And the overall research landscape for KAP, specifically in eating disorders, is still, well, pretty new.
Extremely early days. There are currently no large-scale randomized controlled trials, the gold standard in clinical research, that have looked specifically at KAP for eating disorders. This study is a valuable piece of the puzzle, but it represents a tiny fraction of the evidence base we ultimately need.
So what are the big unanswered questions that researchers need to tackle moving forward in this area?
Oh, there are many. We need much more research looking at different AN subtypes, restricting type, binge purge type, different levels of severity, different age groups. We need studies comparing different dosing strategies for ketamine, different frequencies of treatment, different routes of administration like IM versus PSI-IV versus maybe intranasal. And we need standardized ways of measuring outcomes consistently across studies.
And understanding long-term effects.
Absolutely. Understanding what helps sustain any potential benefits long term and how best to prevent relapse, which is sadly so common in AN, is paramount.
Mhm.
And we also need to be acutely aware of and carefully manage potential risks and triggers that might be specific to the AN population when using ketamine.
Like what?
Well, side effects like nausea or vomiting, even if temporary, could be extremely triggering for someone with an eating disorder focused on control or purging. That reported surge of energy some feel post-ketamine. That could potentially lead to excessive exercise if not monitored and managed carefully. Even routine pretreatment procedures, like getting weighed, could be significant triggers for some individuals.
And that post-treatment weight loss issue we discussed earlier.
Precisely. It just hammers home the point that any treatment for AN, even one that shows promise like KAP seems to in this case, requires meticulous pre-treatment assessment and collaborative planning. It needs close monitoring during the treatment, and maybe most importantly, it demands a robust, highly individualized plan for follow-up care and ongoing support after the acute treatment series concludes, especially concerning weight management, eating behaviors, coping with triggers, and overall well-being.
So for you, the listener, may be curious about ketamine for conditions beyond depression. Why does this one single case study matter? What's the takeaway?
I think it matters because it provides a tangible hint, a proof of concept almost,
Yes.
that the potential of ketamine, particularly when thoughtfully combined with therapy, might extend to conditions that have historically been incredibly resistant to our existing treatments, like anorexia nervosa. It opens up a genuinely new avenue of hope and, importantly, of research.
And it really reinforces that key point. It's not just about the drug itself, is it? It's about the context, the integration.
Absolutely. I think this case strongly supports the idea that it's how ketamine is used when it's carefully integrated into a therapeutic process, specifically designed to leverage that potential window of neuroplasticity and psychological flexibility that could be the key to unlocking new possibilities for patients who've been stuck for a long time.
So it sounds like a genuinely exciting area of research, but definitely one that requires more careful study, more data, and real clinical expertise to implement safely and effectively.
Precisely. It's a very promising avenue, and individual case reports like this are incredibly valuable and encouraging. But we have to remember, for a condition like AN, known for its chronicity and high relapse rates, this isn't likely to be a simple magic bullet. It demands rigorous scientific investigation, and it requires comprehensive, skilled, and highly tailored clinical care. Preparation, integration, and follow-up are likely crucial.
That makes a lot of sense. It leaves us with a fascinating thought, though. If ketamine, perhaps by enhancing brain flexibility, can help open a window for change and potentially challenge those deeply ingrained, rigid thought patterns in a condition as notoriously stuck as anorexia nervosa, what might that suggest about the potential for similar combined therapies? Using agents that boost plasticity alongside therapy for other disorders where people get trapped in fixed ways of thinking or behaving. Something to ponder.
Indeed, a very interesting question for the future.
Well, this case study certainly offers a compelling glimpse into the potential role of ketamine-assisted psychotherapy in treating anorexia nervosa and its related conditions. We saw some promising outcomes in this one individual's complex journey.
Absolutely. And while these early findings are certainly encouraging and warrant excitement, it's clear that extensive further research is essential. We need that to fully understand how best to utilize these kinds of therapies safely, effectively, and ethically within the challenging landscape of eating disorders.